My name's Liz Ledger. I'm a paediatric emergency medicine consultant and one of the paediatric advisors for MSF France. We're now going to start our Q&A session. I'm hoping lots of people have got some questions burning to ask our panel of amazing expertise up here. I am so thrilled that we have chosen to focus on this topic to start our conference and think about conflict in children. I mean, I'm very biased as a paediatric emergency medicine doctor. I spend a lot of time thinking about it, looking after children who are injured, teaching it, and I know that it is a topic that tends to fall through the cracks. As paediatricians or paediatric nurses, often we feel uncomfortable in the emergency or the resuscitation room. As emergency doctors, general doctors, then we can also feel nervous about treating a child, may not have the right equipment, may not have the right training, the right tools, and we've heard a lot about that already from our panelists so far. There was an experience for me back in October 2023 that really made it clear to me that I wanted to focus on this topic today, and it was right at the beginning of the Gaza conflict. There was a meeting taking place to do some planning around our MSF response to that, and I was told that as a paediatric advisor I didn't need to attend because there were no children that were making it to our MSF health facilities. Now, our MSF charter is that we exist to provide support for victims of conflict, victims of disaster, natural or man-made. And I feel very strongly, as we've heard today, children are significantly more impacted often in these disaster situations, conflict situations, and that this topic is very much what we as MSF should be doing, hopefully are doing. And so on that, I'm going to take the moderator's privileges and ask the first question. We haven't introduced him yet, but Chris is sitting at the end. He's our ops representation. He is Dr. Chris Hook. He's an emergency physician from the UK. He's also Deputy Medical Head at MSF Brussels for the emergency pool. So Chris, today in MSF, how are we doing treating injured children?
Yeah, thanks very much. Easy question. I mean, we've heard today some really stark numbers. The numbers of injured children out there in conflicts are massive. And certainly in my career, one of the things I thought about was, I think if I want to be involved in MSF, we see a lot of kids, so I need to be relatively comfortable with kids, and then I need to be relatively comfortable with trauma because we see a lot of trauma, and I'm really appreciative that MSF now are bringing this as a real focus to combine those two, because we've heard already that experienced trauma clinicians are not comfortable with kids, even when you've experienced lots of mass casualty. And the experience now of MSF saying that paediatricians don't need to be involved in trauma. So I think there is a lot of good stuff going on, but what we've got to be aware of is that we work in many of these places where these children are at risk of conflict injury, and MSF as an organisation, in many of these places, we sort of are expected to provide and bring the gold standard to the care that's being provided. And our reputation for doing that is often what gets us access. And our ways of working tend to get us to places quickly and with the ability to respond in a large way. And with that comes a responsibility to do things well. And I think if we turn up and we say, yes, we can run a trauma centre or we can run an emergency room, but we don't really like the kids' side of it so much, then we have no business trying to say that we can do that. We're talking a lot today about the certain phases of the injury. I mean, we barely touch upon pre-hospital care a lot, and community training for paediatric injuries, almost non-existent in most of our programming. But this goes all the way through to rehab of these injured patients, as well as their surgery, and then their mental health support at the end as well. And there are loads of amazing things that are being done in MSF, but with that responsibility, like I say, I think we can do a lot of things a lot better. And we don't need super advanced experts in most of the contexts where we work. We've heard from Paul Reevely the basics of simple care, doing things well, understanding the few key differences for an injured child versus a medically ill child, or the difference between an injured child and an injured adult. It's not a lot. And so I think just doing those basics well, pushing this as a topic so that we are all up to date, all the clinicians in the field and people developing programming are aware of what our limitations are. Do we have the right equipment? Do we have the skill set? Do we have people trained? And making sure that we, as a group, as an organisation, are able to feel confident in ourselves that in our programmes we can do this, but also that we can pass that confidence on to the people around us, that they can trust us to do this well, and if they follow what we're doing, that things will improve. So, like I say, in many of the contexts we work, I follow Gaza from the headquarters, and recently we're talking a lot about what comes next in Gaza if this ceasefire holds, and I talk to a lot of people about should we specialise, should we push for paediatric surgery more, should we push for paediatric rehabilitation more, what about mental health for injured children? And the response is always, ooh, yeah, but I'm not sure we have that as a clear specialty yet. And so should we be doing it? And I think, yes, we are the sort of organisation that should be driving this forwards. So it's really great to see so many people here as part of this conference, and really great that you've highlighted this as an area for us to work on to improve. So thank you.
Thank you, Chris, and sorry to have leapt on you for the first questions. Have we got a moving microphone for the Q&A? Just getting hold of some microphones. Keep your questions ready. Yeah. Thank you.
Thank you very much. My name is Fawzi Al-Hammouri. I'm a pediatrician. Also, I'm a hospital manager. Also, I'm the chairman of the Private Hospital Association in Jordan. But we also established the Gaza Health Initiative in November 2023, 1 month after the war on Gaza. And I must say that we have been collaborating with MSF Jordan and MSF Gaza, and I would like to thank them for all the efforts that they are doing to help the people, particularly the children in Gaza. And I really look forward to have more collaboration in making the mission of bringing 2,000 children from Gaza to be evacuated to Jordan for treatment and then to be sent back to Gaza. This is the initiative which was brought by His Majesty King Abdullah. We already brought more than 300 children. Now they are in Jordan, treated in different private hospitals, including MSF Hospital. I have a guest from United States last month, Professor Jeffrey Goldhagen. He is the president of an international society for social pediatrics. He is advocating that the pediatricians in the world, who count now 1 million pediatricians, are the best witnesses of the agony and the pain the children are having in conflict zones. Are we as pediatricians doing that? Are we documenting what the children are suffering in conflict zones? Are we providing testimonials in different media or courts, wherever we can? Because we are the closest to the children. We are seeing the trauma, we are seeing the agony, we are seeing the pain, we are seeing the killing of these children. So I'm calling for every pediatrician in this hall and everywhere in the world to be a witness. Witness on the crimes committed on these children, wherever they are, in Gaza, in Sudan, in any place in the world. So this is my message, and this is my question for my colleagues all over the world. Thank you very much.
Hello. Thank you very much for that. I wondered, Mohammed, maybe, would you like to respond? Is there a microphone just here?
Yes.
There we
yeah.
go.
It's okay. Thank you. Thank you, Dr. Fawzi, for highlighting this point. It's my first time to say, me as a kid, I was treated in one of the MSF facilities when I was injured in Gaza. It was like more than 15 years ago. It wasn't a bad injury. So MSF has been doing a nice work around. But as a doctor during this genocide, when Ashifa Hospital has been invaded and I've been forced to move to the south, I've been appointed by the Ministry of Health to change an administrative building to a hospital. And this hospital needs to be handed over to MSF, and they will bring the workforce to run this hospital. They called it later Indonesian Hospital in south of Gaza. So I was the clinician who was responsible to prepare this building and transform it from administrative building to a facility to treat injured people. Unfortunately, again, all the equipment that I have was for adults. No, like very simple equipments like cuff for blood pressure or airway equipment or whatever. Nothing was available for kids. And then we handed this over to MSF. I wouldn't say this is the fault for the Ministry of Health or this is the fault for MSF. This is the fault on all of us that we don't advocate for this to happen. This is the fault that we heard from you as well when you have been told that pediatricians don't need to be involved in this kind of stuff. And we have heard from my colleagues here about the numbers of peds or kids who has been injured during conflict. This makes a responsibility on our shoulders to advocate for this, to make sure, hopefully there is no conflicts happening in the future, but anyways, it's happening, to make sure that kids, they will have the right to be treated equally as adults and more, because they are vulnerable people. This is in terms of the physical impact on kids. I've highlighted about the psychological impact. Imagine 3 years old kid coming to hospital without any family member, and just this kid seeing my face, like taking a pen, writing kind of numbers and letters in their bodies, rushing them to the emergency room in recess, and doing the stuff that we do as an emergency doctor without saying, just like we say in Arabic, Habibi ihda, or calm, like a little one. We don't have time to say this as clinicians, because if we spend saying this or calm them down, other people will die. So we need to highlight as well the psychological impact as well.
Thanks. I just wanted to say something on that point. I mean, advocacy is really important, isn't it? I mean, it's part of the partnership thing that we do. Save the Children do our advocacy, we write books, Imperial College do the research. It's a huge part of it, yeah? But in this room, is there any further argument you need as people involved in this, you know, all the right people in all the right places with doing all the right things? Do we need to win this argument here to say we need to program something, we need to train our staff, we need to buy a few bits of cheap, high-impact equipment? Advocacy is vital, we all have to speak up, we've got a moral duty, but I don't think many organisations who are in the parts of the world that are meeting these children need to be persuaded. It's within our gift, I hope, and I don't know how they are structured, but it should be within our gift. We don't need to be persuading each other, we just need to be doing.
Thank you, Paul. I think there were some questions over here. Have you got the microphone?
Yeah, thank you. First of all, thank you so much to all of the presenters for really powerful and very thought-provoking presentations. Just a quick question on sort of, I guess, next step forward. You've identified significant gaps in paediatric trauma care. And so just thinking about moving forwards to equip both our facilities, so our physical spaces, and also our workers with the skills and the ability to give the quality of trauma care for children that we'd all wish. So just thinking about practical next steps forward, if possible.
Great. So maybe Chris, Paul, and Tanya, if you want to comment on that one.
From my side, it's a bit to sort of from the upside to try and push it on to you guys. There are training courses that Paul has developed that you'll have the opportunity to participate in later this week, some of you. My role in the ops group, I see it very much as trying to bring people together to keep this momentum and highlighting to the rest that we are going to push to do better in our projects at this topic. So to make sure that it maintains a high level of priority wherever we start trauma projects, emergency room projects, and things like that. So I will be trying to push the medical departments to make sure they have mechanisms to put in place the well-trained people and drive those standards.
Yeah, if you want to, yeah.
Yeah, thanks, Michael. I mean, Chris is absolutely correct, and I'll just point a small point of correction. I didn't develop this course. It was Chris and Gavin Wooldridge who were the co-founders of it. So I'm not claiming any credit for it. I've sort of overseen it, and it's of great benefit to the many people who've done it, and kudos to them. And also, Gavin had heavy input to many of the slides that we saw today. This is scope of practice, so how do you develop a capability? There's lots of ways of looking at it in structures, and I'm sure you have one organisationally. The two key things are your people and their training, and then obviously equipment. You can be encouraged that the equipment burden is quite low. You don't need much. Okay, I mean, there's paediatric-sized catheters, there's cannulas, there's all that kind of stuff. Surgical procedures with, that if you're scared of that kind of capability development. If you looked at every child operated on in coalition facilities in Afghanistan, there were no specific paediatric surgical maneuvers or pieces of equipment required to deliver that care. And there were a tiny handful of paediatric surgeons, and that is absolutely not to say we don't need you, because we absolutely do. And then capability development is yourselves, your scope of practice. We all have to meet our scope of practice, and that is doing the training, that is taking resources with you. Take the manual, it's in 8 languages, it's free, you can use it, you can abuse it, you can chop it up, and you can build your own courses on it. The course is free, so meeting the scope of practice which Chris touched on, you're going to see injured children. You need to be good, you need to protect yourself and them by being ready to deal with them.
Just to expand on the paediatric trauma resuscitation course, which Chris and Paul are talking about, it is running on Wednesday, Thursday of this week. It's a 2-day course. It's a multidisciplinary team simulation-based course, really excellent. And already we've had conversations with our MSF L&D departments where very, very kindly the PTRC team have given us their materials, their sims for us to use and start embedding within our paediatric training initiatives within MSF, which is a fantastic first step. I think there was another question over here.
Thank you to all the speakers. We work in many projects with trauma centres and emergency rooms, but how can MSF address the pre-hospital care gap?
So I think, Tim, that is going to come to you.
Yeah, thanks for the question. I'd say, coming back to our presentation, I think, to Paul's, first of all, that 85% of paediatric patients are dying before they get to hospital. I think is that right? The critically injured ones. Having worked in a pretty high resource setting in central London, even there where you're relatively close to your patients as a paramedic, and there's this functioning call centre most of the time that can get an ambulance or a clinician to somebody quite quickly, you still end up arriving too late at the time for the really poorly people, and I think that's clearly magnified in some of the settings where we're working. What I'm really keen for in the Halo Trust is that we have a similar reputation to you guys in MSF, that we will go to the places that nowhere else will go to, and we'll take risks to get out there. So I think we've got a real opportunity in some of the places where we're working to do things like this community first aid responder project. I'm really, really happy to share all the materials that I've got. I mean, I didn't create them. They came from Extract and the Paediatric Blast Injury Partnership, and are aligned with the World Health Organization stuff. we just have to get on with it. You know, you will also have clinicians working in remote areas who, and I know you're all really, really busy, but I imagine you're probably doing some kind of community outreach stuff in some of the places where you're working. So if you don't need to be a clinician for this curriculum has been designed especially for people who have no medical background and no equipment. And yeah, I'm really happy for us to partner together to do that and get that out there. I think hopefully I've answered your question. Would you like to add anything else?
Can I just quickly highlight as well? It's also you know, you hear time and time again like MSF don't do X, Y, and Z, or we don't do it that way. And I think we need to make sure that everybody that's working in the project understands that that's just not a thing. We have complete independence and flexibility. So if you are working in your project and you realise there's a way that we can cheaply and easily save lives by implementing some form of pre-hospital care, then suggest it and drive it. It needs to come from the projects, like you say. It's, you know, one of the first things we do in any conflict zone is we go and we arrive and we say, oh, we're going to do trauma. Or even before we've arrived, we send teams into places with a sort of, you know, the vision of, well, you're going to a trauma hospital. But we're seeing from the statistics there are things we can do cheaper, potentially more easily and quickly that might have a bigger impact. Now, we might not always find easy ways to capture that impact in the data, and everybody loves to see the number of red cases that we've seen in an emergency department, and that proves that we are saving lives. But we need to just find better ways at convincing people that what we're doing is really valuable, and find for the projects, tell us we can do this here, we have access, we can do it safely, we can do pre-hospital care, and that will more cheaply have a bigger impact on what we're doing. So it's for everybody in this room to take away home. There is nothing that we will not do because we're MSF that might save the lives of an injured child. We will try. So, yeah.
Melissa at the front.
Thanks, everyone. I'm Melissa, Pediatric Nursing Advisor. Perhaps just to follow on from that question, we've talked a lot about pre-hospital care, the acute management of pediatric trauma. How can we continue to address the gaps in pediatric trauma aftercare?
Sebastian, would you like to?
Thank you very much. That is a very good question. I work in a children's hospital in Cape Town, and we cover an area of sort of like 1,000 by 1,000 kilometers. So we get referrals, for instance, with children with extensive burns. They get a superb treatment in hospital, and then they go home, and we never see them again. And that is such a tragedy. So I think the crux is to have a very close relation with the area where the areas where the children come from. So you cannot centralize care for traumatized kids, and you can't, and the aftercare, it has to be in the district. So from the beginning, when the child comes, you should start building a relation with the area where the child comes from, and then take it from there. Because for the kid, it's impossible to travel up and down. So it's crucial that the aftercare is supplied in his own environment. Thank you.
Just to say, even when we were talking about equipment and like specialized equipment for pre-hospital and emergency hospital care for pediatric trauma, I mean, the same applies for post-care. If we just think about, for example, an amputation usually needs on average about 8 revision surgeries for the stump before you even think about moving on to sort of the more lifelong rehabilitation. And then your prosthetics actually have to adapt to the growth of the child. This is a sort of thing that takes not months, but years. MSF's project here in Amman, a lot of people here know I'm a really big fan, not because I'm from here, but because I actually think it does a very unique thing for a region that's ravaged by war. And I wish we could offer more of that for so many people, because it's such a huge gap. I'm in touch a lot with some of the families of patients I cared for in Gaza, and because I've established those relationships, people often reach out to me about other children. And children are sitting in their tents, festering with open infected wounds, with amputations, with no possibilities of rehabilitation, with severe contractures because of spinal injuries. They never receive rehabilitation, so they effectively lose the use of that limb. And it's great that MSF and other organizations want to go in and do the heroic, what we consider heroic emergency work. I will tell you, as someone in intensive care, that one of the biggest causes for morbidity is not the fact that we don't have the acute care, but it's the fact that nobody thinks the aftercare is interesting or sexy or worth or fundraising worthy, when in fact it's really one of the things that most impacts the child's ability to integrate back in the world with a decent quality of life and function.
Thanks, Tanya.
If I can add something, I was involved in the tsunami care 20 years ago. I think it was 2004. And I remember going, the tsunami had a massive amount of attention and media campaigns and donations. 1 year after the tsunami, we did a follow-up. There was not a single social worker working in Thailand to deal with the social problems. It was really horrific.
I think we've now got some questions from online.
Yes, thank you. There are many questions coming from the online audience. So many of them have already been addressed. Just among them, having talked a lot about training today, and training of healthcare workers on pediatric trauma, and training of communities on risk education and first aid, how do we put pressure on decision makers to invest on this? That's a big question.
Yeah, just put your pressure. There are multiple representatives all around the room from ops here. I'm sitting staring them in the face. We want to have this ethos of ideas coming from the project where you're working, where you are experiencing having to deal with these problems. You guys have the solutions, or you have the information that you can give to us, and just keep applying that pressure. Now, like I say, you will often find that people in positions like I have will have a bit of a vision of what we think we should be doing in a certain place, but it's removed often from where we are. And hopefully you'll find that good ideas float to the top and they reach us and we take them on. Our proposals for the next phase of the Gaza conflict have come entirely from the field and what they see as the ongoing needs. This is not me picking what from a distance probably needs to happen. So make proposals, talk to us, and back it with good information, and use the data that you have in the project level to tell us what you think is wrong. The reality is this, and we will listen, I promise you.
Yeah, if I could just add to that as well, one of the ways that I've been approaching this in Halo is just by really highlighting, first of all, because everybody wants to know about the money, don't they? It's cheap, it's almost free. The curriculum's already made, you hardly need any materials, because the whole purpose of it is to teach people how to do this stuff without any materials. There are papers, existing papers, which highlight how good this is, and we're also hoping to work on one as well. And I would also just emphasize the lasting impact of it by teaching people first aid, which doesn't sound that exciting when you're in a room full of such accomplished doctors and clinicians as yourselves. It's so simple, it feels a bit disingenuous, but it will have a lasting impact when you leave that clinic. Like you were saying, when you go back a year later, at least you've left people with some skills to sort of help themselves and help their community. So that's how I do it in Halo. But it's hard, isn't it, to convince people?
If I can add just a quick thing. My message for the policymakers, the question was like how we can address this to the policymaker. I'm sure that everyone here in this room is a policymaker in some way. The message to the policymaker is hear from the local, please. Hear from the local people. The local people, they are the best to tell what is needed. I appreciate your experience. I appreciate that you work in Afghanistan, Yemen, Syria, everywhere. I appreciate that you've been working for more than 3 decades, 4 decades. But please, hear from the local people because they are the best one to tell. If you're not a policymaker, and if you're not a policymaker, you can facilitate your colleagues' voice to be heard to your boss and to your policymaker by putting more pressure. I've been working for Palestinians, Doctors Without Borders, not myself, yours, Dr. Larry. I've been working emergency preparedness before this conflict. We have made a lot of research and tried to So we try to amplify these voices, but unfortunately we are facing pushback from policymakers at some point because we have done this in somewhere and we need to apply what we have done somewhere else to these settings, which is completely different.
Thank you, Mohammed. I think those were really important words to bring this session and Q&A session to a close. The importance of hearing from the field. It's been an amazing session. We have an enormous amount of expertise on this stage, but thank you also to the audience for all of your questions, your participation, and for listening. And for hopefully now we have convinced you of the importance of this topic. I'm sure actually you were all convinced already. You know, sometimes the conversation around paediatric trauma reminds me a little bit of the conversations we were having around neonatal care 15 years ago. We can't do anything to move the dial on neonatal deaths. We need incubators, we need ventilators. Now, I don't know what the paediatric trauma version of skin-to-skin care and zero separation policy is, but I feel as MSF, we should absolutely be leading that innovation. We should be having this conversation. We should be talking about the things that we've heard from Halo, from Sebastian's experience in South Africa, and from Paul around training. So thank you so much to our panel. Thank you to the audience. And we're going to be talking more about the wider context of children in conflict this afternoon. We talk about mental health and the effects on children. Thank you all.